to mention any of those. The views that I'm expressing are my own. They do not reflect any that I've had with Natividad, with the residency, with oral family practice. They don't reflect Epicenter's views. They're simply my own. Another is that terminology and linguistic preferences vary, not just over time have they varied, but they vary between different parts of our community. I do my best to use the most inclusive language I can, but I do, beg your forgiveness if I err, and if I err, please do let me know if the terminology has changed, if I'm using old language. And that the information that I provide here is informational only. It does not constitute medical advice. If you have specific questions about your own medical care, I really recommend calling your doctor. And if you need help either in Monterey County or Santa Cruz County finding physician, I do recommend the website sctrans, as in Santa Cruz Trans.org, where we have a lot of people listed. And if you need further help, feel free to reach out. We can get you connected up. So I just kind of want to take us back and sort of help answer a little bit of historical context for why trans care has been so binary. And it's really not just because we live in a very binary society. It's actually more also rooted in the way that we used to treat gender identity disorder, as it used to be called. Go back 20, 30, 40 years, there was really little to no understanding that there was a spectrum of gender. It was really you're male or female. Also, under the old diagnostic criteria, intersex people could not be trans. And so that just threw a whole group of people out the window. The traditional model and the way that care was given, especially with the old standards of care, is that you went into therapy. You were in therapy for like a year. And then you could go on. Oh, and the real life experience you had to present as your gender identity, whether that was safe or sane to do so. You had to do it for a year. And then you went on hormones. And that after at least a year of hormones, you got surgery. And then your transition was complete. Ta-da, congratulations, have some glitter. The problem, of course, is that this was and is not the right answer for everybody. Not everybody needs surgery to manage their dysphoria. Not everybody needs the typical hormones. The understanding that gender is a spectrum and that there are people who are non-binary, they're androgynous, they're neutroid, they're genderqueer, they're two-spirit, they're whatever, it really is a new, quote, newer concept, and medicine is a little bit scrambling to catch up. That being said, just in the past 5-10 years, there's really been an explosion of availability of care locally here in Santa Cruz County, Monterey County area for people who are non-binary. So let's talk about some of your options and some of the ways that you can modify the care to get more of the result that you need. So we'll start off with hormones. The requirements for hormones are not different. So in general, the requirements for hormones and surgery are not different because you're non-binary. Hormones, you still need to be the age of majority, so 18 or more. You have to not be actively psychotic. You have to be able to consent and understand the treatment and express that understanding, right? So same stuff as before. But some of your options, the first and the most common is doing a lower dose of the hormone. So low dose testosterone or low dose estrogen. This is by far the most common thing that I see. And actually, when I teach other physicians, I point out the UCSF has primary care guidelines that have dosing, and they even have a whole separate column of like, here are the low dose options for people who want the low dose. You can also use estrogen for a while, stop, take testosterone for a while, stop. You don't necessarily have to only be within one box, medically speaking. I don't see any giant obvious contraindications to doing that. Contraindication meaning bad things would probably happen if you did that, so I don't recommend doing that. If you have testes, going on anti-androgens only without using estrogen is another option. And then there are the puberty blockers. And I'm going to spend a lot of time talking about the puberty blockers in just a minute because they are complicated and I haven't really dived into that so far in this series. A word of caution, though, the effects of hormones can be pretty unpredictable. So if it's really important to you to, for example, not have a beard, but you're using testosterone, there's no way to really prevent that. You could go on testosterone, for example, and then get electrolysis or laser to remove the beard. But understand and sort of have that conversation with your physician about what it is that you're actually trying to achieve with the hormone in question and decide whether that's something that's likely going to happen. I recommend, if you look at the WPATH standards of care, which are freely available online, they have a really great table of effects, which I've used in the other parts of this series. I do recommend sort of reviewing that and talking over with your physicians which effects of hormones are permanent and which will go away when you stop taking them. Because that, at least from my perspective, that's one of the biggest things to understand in terms of the risk, so to speak, of hormones. You can't make that breast tissue go away without surgery. You can't raise a voice up that's dropped from testosterone other than with surgery. So I would say in general, if you're going for androgynous or neutroid appearance or body, to kind of go low and go slow and really have that conversation with your physician. I do recommend, in the end, trying to make certain that you have some sex hormones in your body, primarily for bone health. So if you've had your ovaries removed or your testicles removed, I don't recommend just not having any hormones at all. And I don't recommend just being on puberty blockers for a long, long time. The effects on bones take 10, 20, 30 years to really crop up. So a couple of years, 5, 10 years, not a problem for most people. But long term, all bones need, actually estrogen is what they need in order to be healthy. And all estrogen ultimately comes from testosterone. So having some level of some kind of sex hormone in your body is important for the bone health. There are other things that you can do to really make certain that you're preserving bone health if not having a lot of sex hormones in your body is important to your well-being. One is weight bearing and resistance exercise. Get out there and run. Get out there and make certain that you're putting weight on your bones. So not swimming, not bicycling, but walk, run if you can, and do a lot of weights. The forces that are put on the bones actually help the bones to stay strong. Another is getting enough calcium and vitamin D, preferably from your diet. The calcium supplements, yes, they help, but all of the data show us that it works much better if you get your calcium from your diet. So dairy products, and for those who do not consume dairy products, dark green leafy vegetables and tofu and other white beans are also awesome for calcium. You should not take, I think it's about 500 milligrams more than 500 milligrams of calcium at once because your body can't actually absorb it. So 500 milligrams of calcium a couple of times a day. Get out and get some sun if you can. If you can't, vitamin D from pills or from food, preferably. And then the third way is with medications. Really, it has to do with people who are already having weakening bones. So osteopenia, which is slightly weakened bones, or osteoporosis, meaning much weaker bones, where you're at a risk of a fracture. We have medications at our disposal that can help to rebuild some of the bone health. And so if you're at risk for osteoporosis, or if you know that your bones are weak, then talk to your physician about medications. So let's talk about puberty blockers. And to talk about puberty blockers, I really got to talk some biology here. And I'm sorry, please don't fall asleep. So all sex hormones ultimately come through a cascade of different hormones. Welcome to mini medical school. The pituitary gland is where it all starts. And the pituitary gland is in your skull. It's in your brain. It's kind of right between your eyeballs back in here. And that's it here up at the top of the diagram. That produces a hormone called GnRH, gonadotropin releasing hormone, which I will not say again because nobody wants to hear it. That then will cause the release of LH and FSH from the pituitary gland. Sorry. Yes, from the pituitary gland. Been a while since med school. Those then affect the testes or the ovaries to produce whatever their hormones and to produce sperm or eggs. And remember that everybody's got testosterone and everybody's got estrogen. They're just at different levels. So it's not like if you have testes that you're just full of only testosterone. The tricky thing about GnRH is that actually what causes then the release of LH and FSH, which cause the release of testosterone and estrogen, is that it's actually a pulsatile pattern. And that's actually what makes you go into puberty in the first place, is that your brain starts releasing this hormone in a pulsing pattern. So on, off, on, off, on, off, like a light switch. That's what makes the LH and FSH release. That's what makes your hormones release. So if you have a very low level of GnRH all the time, nothing happens. No LH, FSH, no testosterone, estrogen, nothing. If you have a very high level, this all the time, the same thing happens. So we use that basically in medication form. We either artificially make the level low all the time or high all the time in order to shut down the production of sex hormones in a person's body. This is just what I said in text form. There are two different types, GnRH agonists and GnRH antagonists. GnRH agonists, that basically cause the artificially high level. And those are medications like Lupron, which you've probably heard of if you've done any reading on this stuff, or Histrelin, which is Vantas, which is Suprelin. Again, some of these are brand names. Nobody really wants to say Lupron 20 million times, so they say Lupron. Great marketing. And then they're the antagonists, the GnRH antagonists, which are these medications I'm less familiar with because we don't really use them very often in trans care. And so Degarelix or Elagolix are two different examples of that. And I have their brand names here. So we're either making the levels high all the time or low all the time. Either way, there's no LH and no FSH, no eggs, no sperm, no testosterone, no estrogen, nothing. Lower than it even is in menopause, just nothing. It shuts the whole system down. These medications were actually researched and developed for things like prostate cancer and a condition called precocious puberty, where you can have children who are as young as 2, 3, 4 years old going into puberty. That can cause some problems down the road. We don't tend to like 4-year-olds developing breasts, so we give them these medications to buy them more time for their body to develop enough that they can have, a height consistent with most people, for example. We use it in a condition for people with ovaries called endometriosis, where there's bits of the basically the lining of the uterus that causes the monthly bleeding. That actually can go, but instead of going down and out through the vagina, it can go up into the rest of the abdomen and cause a lot of pain every month. So we use it to shut down the hormone systems so that there's no monthly cycle. And then very rarely these days, but historically they have been used along with the depot shot, which you've probably heard about for birth control, for registered sex offenders, which is very controversial. You can go argue about it in an ethics class. In trans care, Lupron's the most common. So that's Leuprolide. That's a GnRH agonist. It's a high level of GnRH. It's an injection only. There's no pill form of it. The most common form that I see is an every 3-month injection. So just like Depo, the Depo-Provera birth control shot. It is important to note that when starting this medication or any medication like it, you're giving GnRH. So you might cause a pulse, which might cause a little burst of hormones before everything shuts down. Don't panic if you see that, it goes away. the other thing to know about these medications is that they used to be super expensive. So I was hearing some parents of trans youth basically talk about, yeah, you could either replace the family car or you could get your child at the time medication for a year. Like, it was expensive. However, Lupron specifically is covered by Central Coast Alliance for Health. So if you have our local Medi-Cal, it's covered. I don't know what the copay is, but it's covered. In terms of using puberty blockers for their puberty blocking effects, this is how we do it. What I typically do, and what a lot of physicians who do this do, is education with the family. So what the best way to use it is when puberty is just starting. Us doctors have a system called the Tanner stages, named after somebody called Tanner. Tanner stage 1, when it comes to puberty and puberty development, stage 1 is your child. Stage 5 is you're an adult. Stage 2 is when puberty is just barely starting. So you're starting to have breast buds develop. There starts to be testicular enlargement. Pubic hair starts to grow. When that happens, that is when I really recommend, if you're going to use puberty blockers for their puberty blocking effects, that's the time to do it, because the goal is to prevent changes which would be distressing, which would cause much worsening of mental health or require surgery to undo in the future. Nobody wants to have surgery because they didn't get a medication. So, let's stop the natal puberty, as we call it, if we can. So the other major way that the really major purpose from my perspective for using a puberty blocker also is to buy time for family discussions. If you remember, I can only give these medications for people who are under 18 with parental consent. And a lot of times, even if you've been struggling with this for years and years and years and years, your parents haven't. They don't know anything about it. And so it sometimes takes them time to kind of catch up. Sometimes there's a lot of distress with one parent or another or one legal guardian. And so when we use a puberty blocker, it shuts the puberty system down, but the puberty will restart normally right where it was, right where it left off the moment that we stop. So this is basically a pause button. And so we pause, stop any permanent changes from happening, shut down the hormones, relieve the dysphoria, and let families and young people have conversations, hopefully with therapy involved, if there really struggles. We can give estrogen or testosterone on top of the Lupron or whatever other puberty blocker we're using. So basic concept is it's a pause button. I just want to introduce the concept of what's called the Dutch model, in particular for treating trans youth. I don't practice under this model, but you might hear about it. And this is kind of how we develop some of the care for trans youth. The idea is still, once puberty starts, you start a puberty blocker. You don't want, if the person has testes, you don't want their voice dropping, because you don't want your voice to drop, right? You don't want that facial hair to grow. You don't want breast development in someone with ovaries. So you continue on the puberty blocker in this model, just puberty blockers until they're 16. Then you start their hormone therapy with testosterone or estrogen to start their puberty. So they go through puberty at age 16. And then you offer them surgery at age 18. This is not how I practice, because I think puberty at age 16 is a little unnecessarily rough. But this is how we started doing trans care for youth. So this is how the puberty blocker thing started. Puberty blockers can be used in adults, though, too. For those who need testosterone, anti-testosterone effects, so anti-androgens, who can't take spironolactone or can't take bicalutamide, which are our other major options, we can use it to shut down the testosterone. It's kind of a big gun. It works beautifully, though. It is not common to use these medications to suppress estrogen for people with ovaries. It's a little bit of a conversation that's going on of whether we need to do that. We don't see any negative effects. So and unlike with anti-androgens, we don't see that we use a lower dose of testosterone if we suppress the estrogen from the ovaries, so it's a little bit difficult to say. That is a conversation. So most of the time we use it in trans feminine people. Couple of notes on safety. The first thing to know is that medications like Lupron, the puberty blockers, GnRH agonists, and antagonists are the fancy terms, are excessively safe. They are some of the safest medications I give. There have been some questions about bone health. As I mentioned, you want sex hormones for bone health, and the effects of them on vertical growth, so how tall you get. But the studies that have been done have shown that, yes, they're affected while you're on the puberty blocker, if you're just on the puberty blocker by itself. And then the moment that you have some sex hormones, everything goes back to normal. The puberty blocker itself has no long-term effect on fertility. Things pause, so we're not allowed to say that it's contraception because the studies haven't been done that show that it's as effective as contraception. But it shuts down all the hormones. So as long as you're proving that the hormones are all shut down, like your chances of causing a pregnancy or becoming pregnant are pretty low. But as soon as you come off the puberty blocker, then whatever your ovaries or your testes start back up again. So long term, there doesn't appear to be effect on fertility of puberty blockers by themselves, with the caveat that if you're using the puberty blocker for a young trans person who, for example, let's say that they have testes, so they have testicles, so they have testosterone normal natally, then if you put them on a puberty blocker and then you give them estrogen and then you keep them on estrogen forever, but they didn't finish puberty, then that person cannot cause a pregnancy. And I really need to stress this concept, like that you cannot create a pregnancy or you cannot become pregnant if you don't finish natal puberty. That is part of a big conversation that needs to happen for families who are in that situation. But puberty blockers by themselves, for someone who finished puberty, as far as we can tell, does not have effects on fertility. I would still have a conversation about fertility before starting them. The side effects of puberty blockers are temporary. They can include things like hot flashes from estrogen deprivation, constipation, depression, memory problems, nausea, headaches, all of the usual side effects. Some side effects that are listed in the packaging, which I don't think would necessarily be problematic for us when we're talking about it for trans care, but of course they mention it. So when the drugs are used for prostate cancer, they note a side effect of breast development for people with testicles. This is terribly upsetting. And then testicular shrinking and difficulty with erections. Again, these are anti-androgen effects. You see them with spironolactone, you see them with bicalutamide. We actually kind of want those effects most of the time. There are a couple of other GnRH agonists besides Lupron. I might as well mention them. Histrelin is another one that's commonly used. This one's an implant, and I'm showing a picture of it here. It's about the same size as the Nexplanon, if you know anyone who's been on that, or if you've been on that before. Lasts for about a year. It does need to be removed. It does take special training to put in either the Histrelin or the Goserelin, so you do need to find someone who's trained to do it. Removing it's not very hard, or for Histrelin, but putting it in as a fancy device and all of that stuff. Goserelin is another option. This is an implant that is absorbed, so it doesn't have to be removed, and it's either monthly or every 3 months. It's just a little subcutaneous under the skin implant. Really doesn't look like it's much different from an injection. I've never used this medication. not covered by CCAH, so I haven't had the opportunity. Most of the time, what I see is Lupron or Hystrelin, or Leuprolide and Hystrelin. So those are the hormone things. So you can have low dose hormones, so low dose testosterone or estrogen. You can use one for a while, stop, use another for a while, stop. You can use anti-androgens only, and the puberty blockers are also an option. I'm kind of throwing them in here as a concept. And obviously, when you're talking about shifting the hormones in your body, then another option also is removal of your gonads. So removal of your ovaries or your testicles is another option. Speaking of surgical options, there are some specific surgical options for non-binary and agender or neutroid folk. So the prep for surgery, the requirements are pretty much the same as it is for people who are more binary. As a reminder, depending on the surgery, you may need up to 2 letters from mental health providers and may need a letter from your regular doctor. Depends on the surgery specifically. So top surgery doesn't need any letters from your doctor, but if you're going to touch your genitals, generally speaking, you need letters from people. If you check your surgeon's website, they usually list it, or you can refer to them in their prior presentations or the WPATH standards of care. There is no formal requirement, like from the World Professional Association for Transgender Health, that a person have a binary identity in order to get surgery. It's usually just been what the surgeon says. So for those who are assigned female at birth or have ovaries or have a vagina, there are 3 major non-binary options that I've been seeing. These are not surgeries that I'm familiar with personally, like as a physician, but I'm reading lots about them, and all these surgeries that I'm mentioning are available from surgeons that are in our vaguely local area, so in San Francisco. One is a vagina-preserving phalloplasty. Another is a vagina-preserving metoidioplasty, and the third is something called nullification. And nullification is basically removal of the external features. So for someone who is assigned female at birth, removal of the labia. So the lips, both the outer and the inner lips, removal of the clitoris, so that all that there is a urethra and an anus on the other end, obviously. But sort of making it smooth so that there's no sex features at all. Surgeries that are available for those who are assigned male at birth or have a penis and testicles. One is a 0 or minimal depth vaginoplasty, also called a vulvoplasty. I've been seeing. You don't have to have a vagina. You can have all the rest of the features with it and have a very minimal depth or no depth to the vagina whatsoever. Another is a phallus preserving vaginoplasty. So you keep your penis, but there's a vagina that's right behind it. Another is just removal of the scrotum or removal of the penis. So that's scrotectomy and penectomy. Again, depending on what you need or want. Like with my other videos, I don't want to be showing pictures of people's genitals. I think cis people like me do that plenty when we talk about this stuff. But if you look around for the surgeons' websites, for those, I specifically am referring to a lot of the surgeons in San Francisco. They do have photos if you need a reference point for what they're talking about. There are also different options with top surgery, and this applies no matter what you were assigned at birth. The incisions can be placed in different positions to give different effects. The contour that they create can be more or less, quote, masculine, unquote, with more or less chest tissue there. The size of the areola, so around the nipple, the colored area, can be larger, more feminine, or smaller, more masculine. Nipples can have more or less projection, again, more feminine or more masculine. And then the nipples can even be omitted. You don't have to have nipples. Be aware that if you do have your nipples removed, breastfeeding would obviously be difficult if you ever wanted that in the future, but You certainly don't need them. So those are really a lot of the options that are more specific for folks who are non-binary. I'd really be interested to hear what people are thinking about this and what more they want to hear about. So I'm gonna shout it out to Haley to pedal us into the Q&A.
Hi everyone. Wow, thank you so much, Dr. Rose. That was amazing. As like a non-binary person, I just learned so much, and I'm like processing all of those options. Because definitely these options are not like talked about and need to be more expressed, especially to our youth and even our older queer community that, you know, still do have these options to be content within their body.
Yeah, they are newer, especially the surgeries are newer. So you're not going to find the pile of research that actually does exist for the older surgeries. So any surgeon should be talking with you about the fact that this is newer. So they haven't done 20 million of them. But they're definitely, like, it's within the past 5 years almost that I'd say that I'm seeing a lot more about this, and it's gone from one surgeon up in San Francisco to most of the surgeons in San Francisco are providing non-binary options or have a page on their website that talks about it.
Oh, awesome.
Yeah.
Oh, that's awesome. Do you know if Stanford does any of these surgeries as far as other than going to San
Don't believe.
Francisco? You know?
No, I don't. Top surgery, I think, but I don't know if anyone doing any bottom surgeries up there. I will double check it. Most of the people who I look at, mostly because I'm used to working in an environment where I can't see anyone with commercial insurance. So I'm used to folks on Medi-Cal and CCAH. And I know of 2 surgeons in this area who will take CCH, and that's for like specifically like vaginoplasty, metoidioplasty, and phalloplasty and top surgery. And so that's Align Surgical Associates in Brownstein and Crane. And so that's who I'm used to. I just look up at San Francisco. So
Yeah. No, yeah, I understand. And just a disclaimer to our youth watching now live or later on that, you know, these conversations are hard to have with parents or families, but just know that the epicenter is there to provide trainings for them, trainings for you, trainings for a wide range of people from so many backgrounds to provide learning experiences and growth. As far as the questions, I have one, which is, can a person take testosterone and then change to taking estrogen, or the other way, or vice versa?
yes, a person can. There's no medical reason why that would be like a bad idea. Oh no. Might cause some mood swings, especially if you go immediately from having lots of testosterone to the other way around. Whew. That one I think would make you cry in a corner most of the day, but you know, it depends on the person. I think that's going to help someone more in terms of if they have no natural sex hormone production. So if they've had their testicles or their ovaries removed and they have no sex hormones, that is the scenario that I see that being the most helpful in. Otherwise, I think most of the time, if the person has ovaries and they make their own estrogen, then simply going off the testosterone will kind of give back an estrogen state. Same, and the other way around. We can also just do estrogen by itself, which I forgot is even an option. Didn't even put it in my slides, but it's totally an option. That is actually how we used to do transition for our trans feminine folks back in the bad old days, 20 some odd years ago, was estrogen only. So you don't have to have an anti-androgen on board either. But again, if you have testes, just taking away the estrogen and the anti-androgen will bring you back to a high testosterone state. But you can totally do that. And I've seen people do that along with low dose T and low dose everything else. There's also no reason why you can't be on, if you have ovaries, why you can't be on both testosterone and like birth control pills. You can actually do that. Or any other estrogen or progesterone containing medications, especially for the purposes of pregnancy prevention. Good times. But we used to think that maybe giving the estrogen would worsen a person's dysphoria, or that there would be problems or it would be less effective. And I actually, at a conference just this past year, saw some OBGYNs talk about it, and they're like, no, actually, we've done the research now and we have a pretty good sense, just use it. So we're not hearing a lot about dysphoria getting worse. So you can use both hormones, so to speak.
Awesome. Thank you. Yeah. Yeah, I'm so glad we have you here because these questions have such a large answer sometimes. And it's amazing. Let's see. I have another one. So as far as puberty blockers, what is the age cutoff to be on those?
Upper age?
Yes.
Lower age? There's no upper age. If you've gone most of the way through puberty or you finished puberty, they're not going to be as like helpful. They're not going to, if you've gone through all the changes already, there are no more changes to prevent. So if you're looking at using it as a puberty blocker or puberty pauser, the deeper you get into puberty, the less changes there are to prevent. But we use the medications in adults. So that's like, you could be 99, 100, 120. As long as you're alive, we could do it. The question then is more, what are you using it for? There are no more puberty changes to prevent, but we can still use it to shut down that whole axis of hormones and just shut your body's sex hormone production down. It absolutely will do that. So, no upper limit. I would say lower limit. I wouldn't use it in someone who's young, who's not in puberty, because why?
Yeah. No, true.
Yeah. I mean, don't give a medication without a reason.
Yeah, most definitely.
But I've definitely seen folks who've had, who's been on Lupron or had the Hystrelin implant as adults for the purposes of blocking testosterone.
Awesome.
But most of the time when we're using it in younger folks, where I generally have seen it used is when there's family conflict. A lot of the rest of the time, if you're sort of creeping into puberty and the family is totally accepting and everybody's like, yeah, let's just put you in the right puberty, then we can just go right to the hormones. That being said, where I typically saw that was also like a place where it was back when we didn't have access to puberty blockers because no one could afford them and no insurance covered it. And so putting someone, for example, who had testes just directly on estrogen was the best course because it was also the cheapest. So different physicians will practice differently. Some really do prefer doing puberty blockers for a while and then putting hormones on top. Some will just go right to hormones when someone's going into puberty. It really depends. And when it comes to the treatment of youth who are going into puberty, who are in that age range, sort of that 8 to 12 or 13 kind of range, who are needing care, I can say that Stanford does do that. Stanford does that, UCSF does that. So those are the people I would call if there's someone who needs help.
Awesome.
And you also mentioned earlier calling Epicenter for help. I can also say one other thing, which is that especially once you're hitting puberty and you're kind of in that phase, there are things that you can talk to your doctor about that we do not disclose to your parents. So that we legally don't have to. So in terms of reproductive decisions, that does not include hormone therapy, but it does include things like birth control, whether or not to continue a pregnancy, things like that. We legally do not have to disclose that to your parents. I do recommend that if you feel like you are needing some extra support, that you find a way to have an appointment with your doctor. And you can ask for it to be one-on-one. How you navigate that with your parents, I can't necessarily help you with, but I can sure as heck give you a hug in my office. So, your doctor's here too.
Most definitely. And I think it's important to, go to a doctor, because I know a lot of queer youth and also queers who are not, under the age of 25, are now going through programs online to get access to testosterone and estrogen. I'm not sure if you know about that, but that's like a big rising program. And I'm very surprised that something like that came so quick out of the 2010s or something. I don't even, but can you talk about the importance of going to a doctor rather than just having a program subscribe you testosterone or HRT therapy?
Yeah. It is definitely preferable to have a physician, especially a local one, and preferably be the same person as your primary care doctor and the person giving you hormones, or at least that if you have two separate providers, that they know about each other and can talk to each other. It's sort of like having all your medications at one pharmacy. We can't know that we're causing harm unless we know everything that's going on. I can't advocate enough for the power of the physical exam. If you tell me that your shoulder's hurting, I could make a rough guesstimate of why over the phone. But that's mostly the most common cause for your shoulder hurting is a rotator cuff injury. So here's what you want to do for that, but I can't examine you and I may miss something like an infected joint. It may not seem like trans care is similar to that, but it actually often is. There's a lot of power to just being in the same room with someone, getting a hug, having those same local resources. So if you come to me and say, I'm getting kicked out of my house, I can say, okay, here are the people locally who you need to call. And oh, by the way, my social worker's just down the hallway. Do you want me to see if you could see them today? And just walk you down there. And the power of seeing someone in person really makes a huge difference. There's only so much I can tell about how someone's feeling and maybe be able to pick up on, hey, you're not yourself today. You're not feeling well today. What's going on? Because I know it's hard to talk to doctors. We wear white coats and have scary things around our necks called stethoscopes. Like, it's hard to talk to us. And so the more that we can break down those barriers, the better, in my opinion. Plus, you fall, you scrape your knee, you hurt yourself, you fall, you cut your hand open, you need some stitches. It's always better to see the person who always sees you, so you don't have to explain all over again why your medication list looks the same way. And a person over the phone can't do that for you. So I'm a big advocate for it. One of the reasons I'm here doing things, it's one of the reasons why I will be continuing my practice in Santa Cruz instead of doing something like those online services, so that I'm here, I'm local. I believe in the power of it, at least, but I'm biased. I also recognize that you don't always have a local doctor, and so I think it's actually really great that services like that are popping up so that people don't have to go down to Mexico.
Yeah, no, most definitely. Thank you so much for that explanation and your, personal reasonings and, that doctor input, because, these programs are fast and easy and, maybe we'll give you the therapy, HRT therapy within maybe 2 weeks, but also there's so much more that goes into it. And, going on HRT is a big, big decision. And I think something quick and easy could be very harmful in many different ways, physically and mentally. So thank you for that.
Of course. I just, I also want to recognize that it's not everybody has that local doctor who will give them the care that they need. And so as long as people are getting their care, that to me, that's always the most important thing. But such it is.
No, definitely. Most definitely. I have another question. Can you talk about the difference top surgery options? I know there's keyhole and also there's some other ones, and which ones are best for breast sizing or for just for the scars also. I know that comes into play.
Yeah. Funny thing, every time the skin is broken, there's a scar. I wonder why. So basically there are two different types. There's the keyhole, and then there's something like the double incision or T-shape top surgery. And what determines which surgery is best for you is multifactorial, meaning there's lots of stuff involved. But one is definitely your chest size. So how much tissue do you have to deal with? If you have anything more than very little chest tissue, most of the time the double incision is going to be a better path. Keyhole really works best for people with smaller chests. So the keyhole is a little tiny incision usually on the bottom part of the areola, so the colored area around the nipple, and then the breast or chest tissue is removed through that tiny hole. There's not a lot of room to work there, and if you kind of sit back and think about it, a larger chest, if you do that for a larger chest, you're going to have all sorts of floppy skin and you're not going to get it all. And it's just, you have to remove some of that skin that's been stretched by the tissue underneath. And so that's why things like the double incision technique, which is you basically take the nipple and areola off. You just cut around them and take them off. So you cut all the nerves. It's important to understand. And then usually there's a vertical cut that goes underneath it. Sometimes there's not, depends on the surgeon. And then a cut that sort of goes underneath like at the bottom of where your pectoralis muscle would be in your chest. So that's the tissue, the muscle that goes right under the breast. And then they remove all the tissue through that larger incision. And then they cut a bunch of the skin so that it all is shaped nicely, and they put the nipple with this typically a smaller areola back on. Does create more scar tissue, obviously. Well, we will have scars underneath the pectoralis muscles. They typically heal very well. Not everybody heals scars well. Some of us make what are called keloids, which are basically the cells and the physiological things that make you have a scar to heal. The scar is your body's way of healing. Overgrow and overproduce, and so you end up with this big gnarly, like, this could be your skin and this would be the keloid on top. You can Google. It's unfortunate. It can be really disfiguring and really difficult for some folks to get keloids. But most people heal beautifully from it. The double incision does affect the sensation of the nipple, which is why I pointed out that it's removed. So that's important to you if that's something to think about. There are other techniques. The other factor besides your chest size that's important is the surgeon's expertise. If the surgeon is used to doing a surgery in a particular way and they've done lots and lots of them, probably not the best thing to do to insist on a specific other surgery from them that they haven't practiced 20 million times, which is a difficult conversation to have with these kinds of surgeries, but is important to understand where their expertise and comfort lie, because that's where they work at their best. So those are some basics. I do recommend looking around at surgeons' websites, understanding, like, you can look at their before and after. Of course, it's never all of the befores and afters they've ever done. But they will usually talk about the techniques that they use, and you'll be able to see what the scar pattern looks like.
Thank you. Yeah, that was my next question, which was like what you should look for in a doctor when looking for someone to do top surgery with. Because I know I've had friends who live in like Orange County who will drive all the way to San Francisco, you know, for that type of surgery. And maybe it's because it comes into insurance, maybe it comes into doctors, like a doctor that they feel most comfortable with. There's so many decisions to make when looking for a doctor. So do you have a sort of like mental checklist that a patient should definitely like check off when looking for a doctor?
Yeah, so when looking for a surgeon specifically for surgery, a couple of factors, and it's really going to be up to you to decide which are most important for you. One, is still and will always be what is their experience level with this? What's their general reputation within the community? If everyone is saying that this is not a great person to go to because they have not great results, it's something you should think about. So that's one. Two is definitely location. I know that a number of folks still go to Thailand for their surgeries. A number of folks go down to Mexico for their surgeries. A number of folks drive from Orange County up to San Francisco. They cross state lines. One, that can get you a great surgeon who's done thousands of them before. The thing that I always worry about is what happens if you have complications. Will you be able to physically get back to them? Is there someone local who can help you? Because can you do that flight back to Thailand if you have an issue with your surgery a couple of weeks later? Can you financially afford that? And could you even physically do that flight depending on what's going on? So I would plan around the possibility that there may be a complication and the fact that you need to get back to see that surgeon. It is always best to, if you have a complication or side effect from a surgery, to see the person who did surgery on you, because every surgeon does does different things. Even removing your appendix, I don't care what the surgery is, taking off your toe. You want to try to do your best to see the same surgeon because they know exactly what happened in that operating room. And they are the best at dealing with their own complications. It also helps them. It is important actually for physicians of all types, physicians and surgeons, to hear back when things didn't go well, because we do change what we do. So that is also super helpful in terms of improving care going forward. The third is, of course, cost. I point out to surgeons who take our local insurance as of, what is today? July 8th, 2021. Who knows? That'll change soon enough. Cost of getting there, cost of the consultation and the surgeon themselves, also availability. It wasn't that long ago that you had to cross state lines unless you were really, really, really lucky that there were like 3 people in the whole United States kind of idea who did this surgery, and so you had to do that. That's less true these days, particularly in California. We actually have a lot of surgeons with a lot of different techniques, and you go just one state over and there are more. So less of an issue here. My personal preference is to think about location as one of the very first things because of that complication rate. I am a physician, and that's one of the first things that I think of is what happens if things don't go the way that I want, or that my surgeon wants. There's also, what techniques are they using? If you have your heart and soul set on a peritoneal vaginoplasty, which is a fairly new development and not all surgeons are doing it, or you have your heart set on a 2-stage vaginoplasty, the surgeons who do those are very, very different and are going to be in different locations. And actually very few surgeons do the 2-stage vaginoplasty anymore. And so you may have to travel to find that. Another example is the colon vaginoplasty, which again is hard to find these days. So it depends a little bit on what you need.
Thank you.
Yeah, I hope that helped answer the question.
No, yeah, it definitely did. Because that is always a thought, that so many of my friends, people in my close community here that always think about, especially here in Monterey County, because, we have options like San Francisco or Stanford or everything like that. But I think it's great to keep local, but of course, a lot of things do come into play to make that decision.
Yeah, I do know that locally there are some folks who will do hysterectomies. There are some folks within 1 or 2 counties who will do an orchiectomy, so removal of the testes. And then if you look at the SC Trans website, there's a broader list of people who will do top surgery than just San Francisco. So that's also why I refer to that list, because I can't keep all the names in my head and they change all the time.
Yeah. Well, I think we're just about time. I do want to ask if we could reintroduce ourselves because the beginning like did cut off a little bit.
Sure.
I'm being told. So if you could introduce yourself and your background real quick.
Sure. I'm Dr. Rose Lovell. Sorry about the cutoff in the beginning. I am a no longer a resident physician at Natividad. Used to be at Natividad. Haha, I'm too used to the old intro. Who will soon be at Santa Cruz Community Health. I'm a family doctor. I also specialize in LGBTQ and other gender and sexual minority healthcare, and I'm here to help.
Thank you. And I'm Haley. I use they, them pronouns. I'm the media content creator of the Epicenter. I'm here today to coordinate this live stream. Usually we have our program director, Jacob, and also our deputy director, Sam, with us. Next time, I'm sure they'll be here and we'll have more of a deep conversation about these amazing deep topics. Like I said, the Epicenter provides LGBTQ plus trainings for professional trainings, family trainings, and anything above. And if you would like to see our website, it's the epicenter831.org. And please follow us on Instagram and Facebook. You can find us at the Epicenter. On Instagram, it is the Epicenter831. But thank you so much, Dr. Rose Lovell. And this was such an amazing discussion. And I hope everyone has a great day. Thank you.
Stay safe. Get vaccinated.